So yes, I'm going to be reviewing a recent paper that was entitled Best Practices for Reducing Pain Associated with Intrauterine Device Placement. This is truly a passion of mine, and this really started as a medical student, observing multiple office gynecologic procedures and, observing really a wide range of responses, interactions between the clinician and the patient, and also just a variety of how pain was managed, for these individual patients. And my project when I was a fellow was looking at the use of oral midazolam during uterine aspiration procedures, and was really interested in just trying to find, different ways to reduce pain. I'm at Oregon Health and Science University in Portland, Oregon, and we've done a ton of research here related to pain, looking at paracervical block, intracervical block, intrauterine, infusions with lidocaine. Use of NSAIDs with IUDs. We've just have really, it's been a hot area of research focus, and is definitely inspiring, just to try to continue to evolve and improve on this area. So this is the paper. It was published in May in the American Journal of Obstetrics and Gynecology. It was an expert review written with other OBGYNs and complex family planning subspecialists, peds, adolescents, family medicine, and complementary and integrative medicine specialists as well. And so what we did is we convened as a group through this virtual medical advisory board earlier in 2024. And we sort of had this 2-hour meeting where we just talked a lot about what we felt like those best practices were. And then sort of a subgroup of us came together to publish this paper. And why did we write this review? At the time that we came together, we didn't really have good national guidelines. The CDC, the Center for Disease Control, hadn't published their recommendations. The American Journal of Obstetricians, or American College of Obstetricians and Gynecologists, hadn't published any guidance as well. And I think we were just seeing a big gap, and that we have all these individual papers published, but not a cohesive way to interpret that. So the goal was really to create practical, evidence-based, and expert-informed guidance for IUD placement. So, we are all acutely aware of the increased media attention of pain experienced during office-based gynecologic exams and procedures. And on a basic level, there has been this normalization of pain as being part of the lived female experience. And our social cultural expectations are that women are capable of enduring pain, that there are these, very specific medical conditions and experiences that women only go through, like a menstrual period, pregnancy, childbirth, or different conditions like endometriosis or vulvodynia. Our society also values the quiet and stoic tolerance of pain. Those that grin and bear it, and those that have spoken up about their pain are often dismissed as having an emotional response or overreacting. This gender bias in female patients isn't unique to obstetrics and gynecology. We see this in treating pain in the emergency room and with different chronic pain conditions. And we also see this bias even more pronounced in treating women of color. We are also seeing sort of this increase in medical distrust related to IUD placement. And this is something that we absolutely can't ignore because many of our patients get medical information on social media. Those that use TikTok, about 65 use it intentionally as a source of health information, whereas 92% of TikTok users have found health information unintentionally. And then 1 in 3 of Gen Z use TikTok as their main source of healthcare knowledge. So that is staggering to me. But the hashtag IUD has close to 2 billion views on TikTok, which is astounding to me. And that number, just keeps on going up. I'm sure it's higher now than when I first wrote this in the paper. Dr. Wu and colleagues in 2023 used a web scraping application to compile the top 100 videos of TikTok, which had the hashtag IUD. And these videos had, at that time, had about 471 million views and over 1 million shares. And the authors found that 97% of the videos highlighted pain, 28% mentioned medical distrust of their healthcare clinician, and about a quarter desired some form of anesthesia during placement. Many of the videos portrayed negative experiences related to pain and informed consent. And if you've seen these videos, they're extremely upsetting to watch. But I think it's really important that we acknowledge these experiences and work to improve. There is, this general acceptance that pelvic exams and procedures should be easily tolerated. And this can lead to dismissive comments and ignoring the pain experience that the patient is having. Like, if you can just relax more, everything will be fine. That the problem is with the patient and not with what you are doing to the patient. So these comments are not always seen as dismissive or said out of malice, but we must also look at the patient holistically and understand that it's not always just a little bit of pressure or a pinch. And we also need to acknowledge the long-term impacts of these procedures that they can have on patients and the creation of medical trauma and avoidance of future care. So I just want to take a moment to dive a little bit deeper into how we experience pain, because the better we understand how pain is experienced, the more effectively we can address it. And so this was, when we were thinking about what we were going to write in the paper, there's these different parts that all need to be addressed. And so on a basic level, pain is the subjective experience that occurs after the pain has been processed by the nociceptive input. And there's 3 dimensions that interact to produce pain according to the biopsychosocial model. So biological factors are the magnitude of the nociception, so how the nerves are processing, the pain, and that could be modulated by inflammation, medication, sex hormone differences, nervous system characteristics. And then the social factors are the cultural factors, social environment support system, and the previous experiences as well. And then the psychological factors are where mood, affect, fear, stress, anxiety, perceived threat, and coping all come into play. And so for gynecologic procedures, you can see how addressing pain is even more complicated. Pelvic structures have a complex array of innervation, making optimal pain control more difficult. Unlike going to the dentist, there's not a single nerve to block. It's really this complex array of nerves. And then, for the social and psychological factors, these are more closely connected to the emotional response, the meaning of the experience, and motivation to avoid harm. There's, elements of the pelvic exam that are inherently triggering, the power differential being undressed, the sensitive nature of the exam. And so when we address pain, we have to address all these factors. And so typically this will be through like a multimodal, pain regimen approach, and then also applying the principles of trauma-informed care and person-centered care. So we'll be going through that. I also just want to address the other thing that is commonly cited, that that clinicians and people might think that, oh, the procedure's just, a minute or 2, it's fine to withhold pain. That it's really because it's a short procedure that, we don't need to really address it, that people can sort of suck that up. And so what I would like to do is go over this phenomenon that's called the peak end rule. And so this is a graph to illustrate where pain is on the y-axis and time is on the x-axis. And, during the procedure, pain is going to wax and wane. And according to the peak end rule, when we look back on prior experiences, our recollection is most influenced by the peak or the most intense point, and then how we felt when the experience was over. And then there's something that's also called the duration neglect, where once you've taken into effect this peak and end, that the duration of the experience really doesn't matter. So I would argue that the time does not matter, that it's really sort of that peak pain that matters. And then the other thing, I just want to give as background are, that there's multiple risk factors for increased pain with a pelvic exam. And, there might be like an underlying pathology like endometriosis or infection or vulvodynia that, is going to have more pain with these exams. This is a 2003 study that they looked to identify specific risk factors, and they identified some, better known risk factors like having history of depression or anxiety, history of sexual trauma. If you're younger, tend to have more pain. But increased pain during the pelvic exam was most strongly associated with a negative emotional contact with the examiner. You can see the adjusted odds ratio is significantly higher for this than other factors. And I just want you to sit with that for a moment because that is something that clinicians can actually have control over and can really change that experience for the patient. So I'd like to turn our focus back to the IUD placement. And so there have been multiple studies looking at pain with IUD placement. I just want to highlight 3 of them. The green is the percent of the study population that has no or mild pain. Yellow is moderate pain, and this pink-orange is severe pain. The first study on the left is 221 nulliparous patients. So have never had a pregnancy or given birth, receiving a levonorgestrel IUD in Sweden, and 72% experienced moderate pain, but 17% did have severe pain. In this study, most patients received some type of analgesia, and only 13% didn't have any pain relief. So that includes different forms of nonsteroidal anti-inflammatory medications or local anesthetics. The middle study was among Paris women, so who have given birth before in Finland, receiving a levonorgestrel IUD after removal of an expired one and placing the new one, and found that 54% had moderate pain, 11% severe pain. And in the study, no additional pain medications were used, except one patient did receive a numbing block. And then the last study is a little bit more recent one from 2023, looking at over 1,000 women in Brazil that received either a copper IUD or a levonorgestrel IUD. And about a third had never been pregnant, a 2/3 had a pregnancy, and they found that 31% had moderate pain, but 50% had severe pain. In this study, no analgesics, anesthetics, or cervical priming or nonsteroidal anti-inflammatory medication were used to avoid influence the pain assessment. So I think for me, that study is definitely the most telling of how much pain to expect. Looking at this question a different way, I also want to think about the clinician observed versus the patient experience of pain. Several studies have looked at the accuracy of providers' assessment of pain. And in this 2014 McGuire study, clinicians underestimated pain at 3.5 out of 10 versus 6.5 out of 10, which is what the patient experienced. Another study in 2015 showed similar findings. And these findings aren't all that surprising, as clinicians do tend to rely on these nonverbal cues, but the implications of under-recognizing pain leads to not only under-treating the pain, but can also lead to medical distress, compromises the autonomy of the patient, because if they had known it was going to be more painful, they probably would have chosen a different option to alleviate their pain, and can also lead to this avoidance of future medical care. So in our paper, we try to give these really comprehensive guidance for not only for the clinician, but for the clinic as well, the clinic practice managers, staff, the schedulers, the medical assistants, because it really is a whole team that is going to make a big difference here. I realize that this text is very busy on a slide. It's hard to read, but it's just one of the figures from our table. And what we need to emphasize is, again, that entire experience, from that phone call, giving accurate information, telling patients how to be prepared ahead of time, what to expect, and also consistent messaging for patients regarding how to prepare for the visit. But we, sort of just highlight these overarching principles: trauma-informed care, shared decision-making, that personalized care, creating that therapeutic alliance, sort of building that trust, that rapport with the patient. And then also going into the staff training and service philosophy of how to, support the patients the best. So, the scheduler should be able to, tell them, what to prepare over the phone, or provide, written information ahead of time. That makes a huge difference. This is also part of the that table that goes through sort of the principles of patient-centered counseling and use of therapeutic language and verbal analgesia. But really this, part of this is when we think about trauma-informed and person-centered care, we think about that cultivating trust, seeking to understand prior experiences, creating that safe physical and environment for everybody, regardless if they choose to disclose any history. That recognizing that a lot of times the patient has the answer, asking them what's gone well or poorly in the past, giving them realistic expectations. And then, really going through a thorough informed consent so that the patient knows exactly what to expect with the experience and recovery afterwards. And then giving patients, all the pain options as well is really important, that we can sort of maybe highlight patients that might be at risk for increased pain, but it really is sort of based on what the patient's expectations are. If a patient doesn't want to feel anything, then probably their best option is going to be some form of sedation. If the patient is okay feeling a brief amount of pain and they just want to get it over with, then that's okay, but also making sure that the patient has permission to sort of stop at any time as well. This is, some information that we sort of, just practical information for the administrative and support staff to give patients ahead of time, just to make sure that the patients are sort of prepared of what to expect. And then we also sort of highlight, again, sort of those different risk factors for increased pain, because it is beyond the obstetrical history. That obviously plays an important role, but it's important to sort of identify those other factors as well. And then, just also recognizing that a lot of the social media has really created a negative expectation for our patients. And I absolutely always ask my patients, what have you heard? Like, what have you heard from your friends or family? Have you seen, any social media videos? Because I want to know sort of what their concerns are, what their worries are, so that I can address those and be attentive to those. As far as interventions go, we have sort of lists of non-pharmacologic and pharmacologic options, throughout the paper. We talk a lot, about the use of our words really mattering a lot. And, in one study, this use of vocal local or Verbicaine was just as effective as using tramadol, which is a opioid-like pain medicine, in improving pain. And so that involves, focusing the patient's attention, engaging them in conversation, talking to them in a soothing, reassuring voice, providing anticipatory guidance, checking in with the patient, making sure that they're safe to sort of continue or proceed. And so, it is sort of building that trust, which is so important. Another study found ultrasound guidance to be helpful. This is obviously not feasible in most clinical situations. Not every clinic has an ultrasound, but that can be a helpful tool to have as well. Some of the smaller framed IUDs are less painful. So I've definitely had patients choose a smaller frame IUD just because they were concerned about pain. We use a lot of heating packs. That's helpful just in treatment of dysmenorrhea. It can be used for office-based procedures. There's some ongoing studies looking at TENS units, which is a really great option just because it can be sort of added in the moment, doesn't need to be planned ahead of time. Patients can still drive themselves home. The use of lavender oil can decrease anxiety, but doesn't decrease pain. Some patients really like those options. And then, that it can be placed at any time during the menstrual cycle. The other things that we think about are just sort of the optimal environment. And, this again is very much about patient choice. Some patients don't want the lights dimmed. That might be too triggering for them. Other patients, might want to play their own music or have you choose. I have like a little handheld fan that like my patients love because they just like a little bit of that distraction. And it's probably one of the most surprising things that I've gotten feedback on. I probably need to like study that in some way, but it really is about that patient choice, and sort of involving them of like what would be helpful for them. The complementary and integrative medicine considerations that we talk about in our paper are use of different aromatherapy, acupressure, acupuncture. We have some specific acupressure points that can be helpful. I am not familiar with some of these, like the Reiki, I don't do, but reminding the patient to breathe, doing some more guided imagery. You can do these like isometric contractions of your arms and legs just to help prevent that like vasovagal reaction that can sometimes happen. We talk about, use of different nonsteroidal anti-inflammatory medications in the paper, and none of them are, a slam dunk, but they can also just sort of take away some of the cramping, especially after the procedure. I think it's more helpful for. Probably the most promising are either naproxen or the ketorolac, either given as an oral or intramuscular. The main problem with the ketorolac is that you do need a prescription beforehand. And then most of these take at least a half an hour to 60 minutes to get peak effect. So timing of that medication is really important. And so that does go into sort of the pre-procedure planning that happens even before the visit. There's no evidence to suggest that cervical priming with misoprostol helps. It can actually increase cramping, pain, and side effects. For a failed IUD placement, there's one study to show that it could be helpful. This looks like this medieval torture device, the cervical stabilizer. We have traumatic or atraumatic. There's really no difference in using that just because it's more of the pressure. But this is probably one of the things that I stress to my trainees the most is that you absolutely need to numb the cervix. You need to do something before you place this. You can't cough. You can't just slowly click it down. That it does not work. And so sort of emphasizing that the cervix is numbed, with using something on the cervical stabilizer like a tenaculum. And then we talk about, other local anesthetics that can be helpful. There's evidence showing the paracervical block or intercervical block of lidocaine. I have a lot of patients that do have needle phobias, and the thought of a needle going around their cervix is terrifying for them. So there are options of using like this lidocaine prilocaine cream on the cervix. I think it's not available in the US, but I'm not sure if you guys have available a lidocaine spray. That would be honestly probably one of the best things for people. And then, we have these other options like nitrous oxide. We have that in our clinic. That sort of is more an anti-anxiety medicine than a pain medicine, but it does improve patient satisfaction. They really like to be able to control it because it's all patient breathing in. Use of anti-anxiety medicines, we use that frequently just because patients are asking for it. They feel anxious and they kind of feel like if they can, take something to sort of help calm their nerves, that they'll be able to get through it. That also involves pre-planning because the patients do need a ride home. And then we do a lot of IUD insertions with moderate or deep sedation, especially those with a history of trauma, prior negative medical experiences, pelvic pain, in a lot of teenagers as well. So that's something that we commonly use. And these are some of the more common anti-anxiety medicines that we use. This is sort of our comprehensive table from the paper that we really try to make it a quick reference point for, busy clinicians to use in, teaching settings, especially, and sort of a workflow going through of sort of how to help patients the best with getting their IUD. I do find that it can be very overwhelming talking to patients about all their options. These are not my clinics, but I have seen these little almost like menus to talk about sort of, what would be best, what they would like for their IUD insertion. And then, for the Center for Women's Health, which is where I'm the medical director, we have information on our website. And then we recently just we made a very comprehensive guide to patients when they schedule for their IUD that goes through step by step what to expect throughout their entire experience and a comprehensive list of all of our pain medications as well. So just my, final thoughts, and I know I'm preaching to the choir here, but, that we just must absolutely stop normalizing inadequate pain control during gynecologic exams and procedures, and that standards of practice for pain management need to not only prioritize patient comfort and well-being, but also grounded in trauma-informed care. So I always I'm recommending that, talking to the patient about what to expect with the procedure, having an honest discussion about how much pain they could expect, review all the pain options, and come up with a plan together. Ask patients what they've seen on social media, what they've heard from their friends and family, and what their prior experiences were as well, and their pain expectations. Again, some patients might be okay with 6 out of 10 if it's a short amount of time, they're fine with that. Others are not. But at no time should you ever minimize pain or talk patients out of the pain relief that they desire, because it's not always just a cramp. And then, just that there's not a one size fits all approach, that we can't make assumptions. I've had multiple IUDs both before and after I had children, and my more painful placements were after I had kids. So I can't use obstetric history. It's not blanketed for everybody. I can think about my own experiences. But each patient will need something different. And, using this multimodal approach usually works the best. We've also worked really hard to break down barriers to get IUDs and do same-day IUD insertions. But I think some patients really need to have, a visit where they talk about everything, come up with a pain management plan, have time to think about what IUD they want, and then, coming back for the IUD under the terms that feel more comfortable for them. And so I think, also just being okay that some patients need more support and planning. So that was all the slides that I have, and I'm just going to stop sharing here.